Dear friends, we are going to discuss today the antiphospholipid syndrome. If we talk about the antiphospholipid syndrome is basically a autoimmune disease. Then this autoimmune disease is basically responsible for the vascular thrombosis, arterial or vascular thrombosis. Now the most important thing is the disease may be associated with the pregnancy morbidity or may not be associated with the pregnancy morbidity. So this is the disease, this is the autoimmune disease which is basically responsible for the venous or arterial thrombosis and may be associated with the pregnancy morbidity or may not be associated with the pregnancy morbidity. So now one thing which is responsible for the disease is the antiphospholipid antibody. And this antiphospholipid antibody is basically may be produced transiently. This antiphospholipid antibody may be produced transiently. And how can it can be produced? It can be produced by infection or it can be produced by certain kind of medications. So infection can produce these kind of antibodies or some kind of medicines can produce these kind of antibodies, and these medications may be the minocycline, maybe the hydralazine, maybe the amoxicillin, or may some beta blockers like propranolol may produce the transient antiphospholipid antibody. Now if we talk about the disease, basically particularly in SLE patients, 1/3 of the SLE patients are basically associated with the disease, and basically this is the independent risk factor for the renal failure and pregnancy morbidity. So this is the independent risk factor for the renal failure and pregnancy morbidity. So if we talk about the SLE, 1/3 of the patients of the disease are associated with the SLE, and these are the independent risk factors. This is the independent risk factor for the renal failure in SLE patients and pregnancy morbidity. Now if we talk about the antiphospholipid antibody, 10% of the pregnancy losses may be associated with the antiphospholipid antibody. 15% of the stroke patients or cardiovascular accident patients may be associated with the antiphospholipid antibody. 10% of the MI patient may be associated with the antiphospholipid antibody, and near about 10% of the patient may be associated with the deep vein thrombosis. So this is about the association. Now we talk about the pathogenesis, brief about the pathogenesis. If we talk about the pathogenesis, actually what happens if there is endothelial injury, if there is some kind of endothelial injury because of some other causes, there is an endothelial injury, what happens? We exposed the phospholipid binding protein, and because of the exposure of this phospholipid binding protein, what happens? There is the activation of the inflammatory cascade, and this activation of the inflammatory cascade will lead to activation of the complements, and this activation of the complements will lead to thrombosis, will lead to vascular thrombosis. Now we discuss about the diagnosis. How do we diagnose? So to diagnose the patient of this antiphospholipid syndrome, we have certain criteria, and the criteria may be the clinical and the criteria may be the laboratory. If we talk about the clinical criteria, so we are going to discuss about the criteria, diagnostic criteria of the antiphospholipid syndrome. So in diagnostic criteria, we are supposed to see first of all the clinical criteria. So if we talk about the clinical criteria, we are supposed to see the two things. One is the vascular thrombosis and number two is the pregnancy morbidity. If we talk about the vascular thrombosis, whether it is a small or large vessel thrombosis, there should be one or more than one vessel should be involved. And if we talk about the pregnancy morbidity, there should be the premature birth before 24 weeks, and it should be one or more than one. And basically if we talk about the death, premature death, it should be one or more than one. So basically if we talk about the pregnancy morbidity, and this premature birth or death may be associated, and this comes in the clinical criteria. This premature birth may be associated with the eclampsia, preeclampsia. So if we talk about the clinical criteria, we are supposed to see the vascular thrombosis and we are supposed to see the pregnancy morbidity. Now the laboratory criteria. If we talk about the laboratory criteria, in laboratory criteria, basically what happens, we are supposed to found positive two or more than two antibodies. One is anti-beta GP1 antibody. Number 2 is anti-cardiolipid antibody, and number 3 is the lupus anticoagulant. So it should be 2 or more than 2 antibody should present. So this is the laboratory criteria. Now, what are the renal manifestations of the disease? If we talk about the renal manifestation of the disease, the patient may present with the vascular thrombosis, renal vein or renal artery thrombosis. The patient may present with the hematuria. The patient may present with the acute flank pain. If we talk about the renal manifestation, the patient may present with the proteinuria, the patient may present with the active urinary sediments, and the patient may present with the AKI, or the patient may present with the AKI on CKD. So these can be the renal manifestation of the disease. If there is a renal vein or arterial thrombosis, the patient may present with the acute flank pain or hematuria. Beside this, if there may be the AKI or AKI on CKD, the patient may present with the proteinuria, the patient may present with the urinary actic sediment, etc. If we talk about the treatment, so if we discuss the treatment, we are supposed to give the anticoagulants. And if we talk about the anticoagulants, we can give the heparin, we can give the warfarin. If the warfarin is contraindicated, then we can give the rivaroxaban. Particularly in SLE patients, the SCQS is important to prevent the secondary thrombosis. So in SLE patients, to prevent the secondary thrombosis, we are supposed to give the SCQS, and SCQS is important in those particular patients to prevent the secondary thrombosis.